Work? Yeah, it seems to work. Thank you so much. That was very generous introduction. So let's see what I can tell you that's going on in our lab right now. So I tried to combine a few of the studies that we do, and so you'll see that I named study 1, study 2. I also referred to some of the students in the bottom of the slide, so you might recognize some of your colleagues and friends. So the lab, should I use this guy? Yeah, I guess so. So we named it Biological Tissue Mechanics Laboratory because we do a lot with heart and cardiovascular tissues, but we've also done studies on skin mechanics, and therefore we wanted to be very inclusive. And so this is coming from all of my labs, and we now have a website, also courtesy of some of our students in the lab and research technician. And like I said, we deal with several types of biological tissues, but we're going to concentrate today on the aorta. Abdominal aorta. The aorta is the largest vessel in your body, as you know. Abdominal aorta down close to the bifurcation into your legs, and then the thoracic aorta. So I'm going to try and keep this at a relatively high level so that I can maybe capture all of you, but we do a lot of mechanics, so please stop me if I'm going too much into details or if something is not clear. I guess we're here to learn and also as a conversation, so please stop me. The pathology that we look at is aortic aneurysms, and again, both in the abdominal aorta, but also in the thoracic aorta, where it's maybe less prevalent, but definitely as deadly, if not more. One of the surgeons that we work with at the Peter Lockheed always tells us, every time I go into my clinics, I have these patients that come to me and I have to decide what am I going to do. Once we figured out that they have an abdominal aorta, the doctor's decision is to whether to operate them or not, what to do, what kind of operation and when. And you might imagine that you could just take everybody who comes in and has a slightly abnormal aorta and operate on them. Well, the problem there is that once you open their abdomen or chest, or even if you do an endovascular operation that's minimally invasive, you're still at the end of the day closing off and going home, and you leave the patient with an abnormal aorta, right? Because the best you can do is you go in and suture in a piece of Dacron, a piece of plastic, okay? So there is no any surgery, any therapy that is going to give your patient back a normal aorta. So that always has to be taken into consideration when you're deciding what to do. At some point you have to decide, so in the last 20 to 30 years, the cutoff has been a geometrical diameter cutoff. So if your aorta is too big, you get into the operating room. This 5 centimeter diameter, the risk of rupture at that diameter, even though it's big, is only about 5% in the subsequent year. So that should tell you that about 95% of patients, right, if you're operating on 5% diameter, 95% of patients may have unnecessary surgery. So should I stop, or should our colleagues stop doing surgery? No, because if it ruptures, you die. So there's really a very difficult, and so in order to, and on the other hand, you can't operate on everybody because the operation is very risky. So that's what we deal with. There's been a lot of studies throughout the years. I'm just looking at a couple of things here to give you an idea of where we start from. So elastin, one of the components, one of the proteins that make up the mechanical behavior of the aorta, so elastin and collagen. Elastin degradation, stiffening, has been identified for many years as one of the hallmarks and one of the characteristics of aneurysmal degeneration. You also have cells of cell death, smooth muscle cell death. And we also found, however, some studies that we did many years ago in Pittsburgh, that wall strength is not directly related to the size. So again, you still have to decide, and when it's big, it's not good, but it doesn't necessarily mean that it's weak. So that means that there are probably localized spots of proteolytic activity that can lead to some focal weakening. And you don't need the whole thing to be weak. One point, one location where it ruptures is enough to unfortunately cause the death of the patient. So I guess our lab tries to link the mechanics of what's inside, what's in the wall, with what's happening at the biological level to try and figure out, can we predict which areas are more weak? And of course, we want to do that in a non-invasive manner, right? Once we have the tissue in our hands, the differences are actually incredible. The same piece can have one region that's very strong and one region that's very weak. However, once we get it out of the patient, it's too late for a diagnostic system. So we have to look at methods that can be then reproduced in a non-invasive way. So this is, like I said, there's a few studies that I'm trying to present. This is study number 1 on the abdominal aorta. The patients come in, and they have a pre-surgical CT scan or MR. We do all of our modeling. We do computational fluid dynamic. We also do our own strain analysis that we've developed. I'll talk about it later. And then we come into the surgical room with a map of the patient's aneurysms with all of our sections indicated on it. And then we have a little table. I'm sure the nurses, I'm sure they go like, the engineers are here. But they're really, really, graceful, and they let us go in with all of our equipment, and we cut the specimens in order for us to be able to bring them back. And again, we want to cut specimens where we know exactly where they were, and we know exactly what was the fluid dynamics, so the blood hemodynamic characteristics at that location, as well as the strain analysis. We bring them back to the lab, and we do a combination of so we bring back all these specimens, and we do a combination of mechanical, histological, and microscopy on the specimens themselves to figure out their strength, the material properties, inflammatory cell counts, percent of elastin, collagen directionality, degree of elastin, degree of fragmentation. So we've done that on a number of patients. We have about 22, including the endovascular, that don't go into an operation. So for those we can only do the pre-op, and we can then follow to see what happens to them after they get operated. The ones that are opened up, we have about 10 of them. But out of those patients, we were able to collect more than 90 specimens. So we have a large number of specimens that we collect. So let's look at what we can do pre-op. We can look at, again, the geometry. This is a very particular case that we call D-double aneurysm. We know them almost by name. We have nicknames. This is D-double aneurysms. In this particular patient, there were 2 formations, one up or one down. These are the iliacs. We can figure out what the thrombus thickness. Sometimes the lumen does not correspond to the outer wall. There is some stuff inside, dead red blood cells and things that are accumulated, possibly, nobody knows, but possibly to reduce the size of the lumen. You still want a reasonable lumen. These aneurysms can reach 10 centimeter in diameter instead of being 2, so that would be too much blood being sequestered at that location. We do maximum principal strain through looking at the movement of the aneurysm throughout the cardiac cycle, and then we do the fluid dynamic analysis from which we can obtain information on whether or not the flow was nice and laminar. Our arteries really like a certain amount of flow. If it's decelerating, if it's going backwards, it's actually not good, and it produces a cascade of signaling that then degenerates the wall eventually. So then these are just fluid dynamic indices, OSI for oscillatory index, RRT that sort of represents if the flow is slowing enough, perhaps to activate the platelets and initiate some cascades of thrombosis. And then what's most important for us, the time average wall shear stress. So that again indicates or pinpoints areas of altered flow. We averaged these, and I was talking about this today with some of the students are even here in the room. We average on these patches that we defined prior to the operation for two reasons. One is because we want to have an idea of so we don't want to have a single node because we need to co-register all those information, fluid, strain, mechanical, as well as we need to co-register everything that we find from our invasive mechanical analysis, histological analysis, right? So we need to have a patch averaged system so that we can know where the piece came and what kind of fluid dynamic was it under. So then we go into the operating room, like I said. This is actually one of those papers that we bring with us in the operating room. We identify all of the specimens that we've taken, and we take notes, thicknesses. Sometimes they have to push us out of the operating room because they have to go on to the next patient, and we're still there doing this. We do a bunch of mechanical tests. We look at stress and strain in the two direction with a biaxial device that's pictured here. We also look at the strength of the tissue maximum stress at rupture through a uniaxial. We look at energy loss, so we perform tests, repeated cyclic test to see if the material is elastic or if there is some energy loss in the behavior. Then we move on to, like I said, histology and microscopy. We do a colorimetric analysis to assess the percent composition of elastin, proteoglycans, smooth muscle fibrin, as well as collagen. We do immunostaining using antibodies against specific CD4 cells, T cells, as well as CD68 and macrophage to try and understand the inflammatory system by area. Again, what's very important is that we don't take the whole tissue and grind it up, but we actually are able to then correlate if there is any inflammation to what was the fluid dynamics, what was the mechanical properties, and other markers. And then some microscopy. Actually, these images may come, we use different microscope across the school, but these probably come from here, from downstairs, from one of the multiphoton in Dr. Herzog's lab. Here's our double aneurysm as well, just to give you an idea of the results that we find. We found a very different, both geometrical, fluid dynamics, and mechanical appearance of these two aneurysms in the same patient. So when we try to say to our surgical collaborator and also to, in the literature, it is really not enough to go in and pick one piece and then say that that represents your aneurysm. They're actually very different. So in this particular case, the upper aneurysm had much more inflammation. There was more thrombus. The fluid dynamic, the flow seems to be more disturbed. However, the elastin still seemed to be relatively conserved. The MTM, so the stiffness was down, and the strength, the UTS, ultimate tensile stress, so the strength was down as well. The lower aneurysm had taken a completely different path. We're also looking at these objects with some RNA analysis that I'm not presenting today with Dr. Rinker's lab. The lower aneurysm had taken a completely different path and had become very stiff and sort of more of an atherosclerotic path. It was stiff, there was almost no elastin, but interestingly, the strength was up. So it was stiff, it was not a normal aorta anymore, not even close, but it was not close to rupturing. So on concluding with our first study, can I go back? Possibly. So we found a high level of inflammation in aneurysmal tissue. It was actually higher in the adventitia. So what we're doing now, we're actually splitting the tissues. I have one study coming after, but we're doing it also. And we're trying to do it on the abdominal aorta. However, in the abdominal aorta, there's almost no layers. So all of those layers are gone. But we can do the adventitia medial analysis by looking at the specimen on imaging or histology when we take the whole through thickness. We had that altered fluid dynamics. So when the blood was stopping, was circulating, was correlating with elastin degradation and fragmentation. The thick thrombus that was often correlated as well with bad hemodynamics, so the flow slowing down was also correlated with the extracellular matrix disruption, and there were huge differences within the same aneurysms as well as across our series of aneurysms. The posterior wall that's kind of abutting to the spine seemed to be stiffer, but also to have retained some of the strength. I guess if it hasn't ruptured yet when we operate on these patients, the fact that they are, and they cannot expand, eventually actually creates, or maybe it's a response that almost goes towards a fibrotic response, but they seem to be stiffer and also have more strength. We're going to move for a second here onto the ascending aorta. What's similar, what's different? We take a similar approach whereby we go into the operating room and we have regions that we collect. And right now, I'm not presenting it, but right now we also, prior to the operation, try to find areas that are very consistent and homogeneous in terms of their, for example, strain or fluid dynamics signature, because that is going to help us figure out what that signature, a lot of strain, bad flow, means in terms of the mechanics and the histology. This that I'm presenting was still on the old same method where we take the piece based on geometrical presentation, so anterior, posterior, large curvature, small curvature. We do a similar set of studies as we do in the abdominal aorta. And what we found, I'm just giving you a few kind of examples of what we're finding. So strength, basically whether or not they're likely to rupture, there seems to be more strength where the collagen is not altered. Okay, so more strength where the collagen is altered. But what does altered collagen mean? And this we collaborated with our pathology colleagues, and altered collagen in the media means presence of collagen in the media. So the collagen definitely provides strength to your wall, but it should be located, or it's normally located most normally in the adventitia, so that the outside of your vessel, and it basically acts almost like a girdle, right? So you can expand to a certain point, but you cannot go beyond. Okay? So when there is collagen in the media, on the other hand, it correlates with lower strength, and as well as it correlates with higher energy loss. So these walls are not behaving like they should. And we're really now looking at what type of collagen, we're looking at total collagen as well as, so these preliminary studies really helped us identify directions in which we want to go. Why is the collagen not providing strength? That's what it does in physiology in the adventitia. Is it because it's in the media? Is it a different type of collagen? Is it a collagen that's not cross-linked? Something is happening, but it's definitely not doing what it does in physiology. If we look at the elastin and the proteoglycan content, again, in some studies, we've seen that some people talk about pooling of proteoglycan as being a negative thing. So the proteoglycan pooling might push the layers of the aorta apart. I'm not saying that's wrong. However, what we found, and we've also seen some other literature findings, a good amount of proteoglycan, it's actually a good thing in terms of energy loss, in terms of it seems to regulate both collagen and elastin. So good amount of proteoglycans correlates with a good amount of elastin, and it seems to be actually protective. So when you start having elastin fragmentation, that's when your energy loss shoots up and your strength goes down. Third study, I could go on, but I promise there's only one more after this. So we looked at same type of aneurysms in the ascending aorta, but we started peeling the layers. So we really can't peel the intima with the method that we're using. So we peel intima and media together, and then the adventitia. Okay? and we test separately with the same type of tests that I've described so far. Biaxial, uniaxial, we do the histology, we do microscopy, okay? So by doing this, we can start looking at what's happening to the media in particular, which we felt was the important thing that was happening in these kinds of aortas or aortopathies. This is just almost healthy. This is an older patient, but no aneurysm. There is a fairly substantial amount of elastin in the media. There's very low collagen in the media. The elastin correlates with quite a linear behavior. So if you look at the red and blue up here, those are almost linear behavior. So it's very easy to deform this media, comes back, doesn't have any energy loss. When you look at the collagen, this is a relatively normal, again older, but normal aorta. The elastin content in the adventitia is almost zero, so that kind of behavior is present. There is the more typical collagenous behavior where it starts being very low, very easy to deform, and like I said, it acts almost like a girdle. You reach a certain deformation around 15%, and it starts, the stiffness increases, you can't go further than that. What we have noticed is that there is a sort of a collagenization of the media, which is also, we see that the collagen starts colonizing the media. It does not reflect into strength, unfortunately, but it does shift. It does shift the behavior of the media from this very nice linear and again no energy loss behavior to a more behavior like this. The only problem is that the adventitia has a very high stress before it ruptures. The media goes towards this collagenization, but the stress at rupture remains low, which is the important point here that I wanted to make. So without showing too many of these results, there's a lot of curves, as you might imagine, but let's just look at this. What do I have here? I have Movat stains, staining elastin. Are these the Movats or the VVG? No, they're the Movats, I think. Staining elastin, collagen, proteoglycans, elastin, collagen, proteoglycans, the nuclei, I believe, and what's the fifth one? Right now it escapes me. Elastin, proteoglycan, collagen, and the mucus, the bluish is proteoglycans and also a sort of a foamy stuff that shouldn't be in the aorta. Okay, so let's look at these images. So here in the top, we have two patients that do not have an aneurysm. They're identified by P as what am I doing today? No, I'm really sorry. So no, this is the control. Identified as control, does not have an aneurysm, and then these two are aneurysm patients, okay? And when you look at P2 and C2, these two are age matched, and P1 is a patient that's much younger, okay? So what we're trying to develop and establish in the lab is that there is perhaps a sort of a accelerated aging when it comes to an aneurysm. Let me try to understand. So let's look at the elastin content. So P aneurysms and C are age matched, are in their 70th decade, I think, of life. The collagen content is very different. There's less. So there has been a more accelerated degeneration of the elastin for the aneurysm patient. Okay? This patient here is a patient that's actually quite young for an aneurysm patient. The elastin content is relatively maintained, but there's still a lot of degeneration in the elastin itself and fragmentation. So the content is maintained, but it's fragmented. So basically, it seems as if when we reach 80, 90, our elastin starts reducing, it starts fragmenting and degenerating, but when you look at an aneurysm patient, that happens at 45, at 55. at 60. Okay. So what is the cause, or at least some of the effects that we can see that could cause these elastin degeneration? So what we're starting to figure out is that, again, this blood not behaving like it should has a huge effect on the health of the elastin, your collagens, and proteoglycans. So this is a study that is done only on the ascending aorta, and it involves, instead of computational fluid dynamics done on a computer model, it involves an MR technique that's called 4D flow that is able to capture the behavior of the blood just directly from the MRI. Okay, so it's not a model, this is actually from the MRI. So we do the MRI, and this study was started whereby the images were coming from, and the specimens were coming from Chicago. We now have an NIH studies where we can reproduce exactly what they do at Northwestern in Chicago as well here. So we have a cohort of patients over there, and then our own Calgary patients, and the patients are done at the Stevenson's MRI Center. So all of the imaging are done at the Stevenson's. So this is the preliminary studies, and we now have 20 more patients done here in Calgary. These patients are from Chicago. So what we found is that elastin degradation and stiffness correlated with wall shear stress. So in an ascending aorta is in particular the high, so the very abnormal high wall shear stress that's impinging in these walls that gets the elastin degenerated. When we look at the abdominal aorta and at some areas as well as these patients, it's also the low wall shear stress, so the blood that is recirculating that's not going enough. Because, and this has been found and studied for many, many years, the blood seems to be a sort of a Goldilocks kind of system whereby too much is bad, too little is bad as well. So taking all of that into consideration, what Miriam, who I think is here, what Miriam started doing is starting to figure out what is a possible disease progression, what is a framework in which we can understand all of these different things that happen at the same time. So, so we have three things on top, and we would love with our next studies to possibly put them in more of a cascade or understanding what comes first. For now, we can't tell you. What we can tell you is that we see that in these degenerated aortas, we have less proteoglycans, we have elastin that starts fragmenting, and we have collagen in the media where it shouldn't be. Okay? The elastin starts fragmenting, eventually the content of elastin starts going down. That goes into changing the properties, the mechanical properties of our aorta, whereby the initial stiffness sort of disappears because you don't have that healthy elastin that takes care of the initial stiffness. You kind of almost have collagen, which operates in a different way. It's almost non-present at initial very low strain, and then it basically starts being activated. And the collagen gets activated at a lower stress. So it's almost a shift of these mechanical curves to the left. On the collagen side, we have that the collagen in the media affects the energy loss, the elastin disruption as well. So more collagen in the media, more elastin disruption, more energy loss. And energy loss is not a good thing. You can just think about it, but think about it in terms of energetics of mechanics. So you have these aortas that are going up and down at each of your cardiac cycle, and they have to do that at a very low loss, right? Because any energy that's lost in a system, in an engineering audience, where does it go? So if I have energy that it's lost every time I stretch and then let go of my aorta, where is that energy going? It could go into heat, which is definitely not something that our body would accept. What else? Damage, right? It's going to start breaking bonds. Collagen bonds, I don't know what bonds it's going to start breaking, but it's certainly going to start breaking bonds. So more energy loss is not positive, and in fact, it's related to lower strength. And then elastins, you want to think of it as decreased elastin. Think of it about, in terms of increased compliance, right? Which is also very counterintuitive. I'm telling you that there's more collagen in the media, and now these things become more compliant, like a vein. Well, the issue is that that collagen doesn't seem to correlate with good mechanical properties. It actually makes it easier initially, and it's related to this. It's easier to pull them initially. Then yes, the collagen kicks in. It kicks in actually before it does normally, but it does not provide a good, healthy behavior. So what we try to do is we try to think, okay, where is this coming from? So is this coming from altered fluid dynamics? And whenever I can get the next one. Maybe like this. Should we wait a second so I can tell you what comes next? So we started thinking, is it the flow disturbances that can be utilized as an index to help us identify from a non-invasive, from images, what's going on at the molecular level. So let me see. Not responding, restart the program.
Sure.
Why not?
Yeah. Why not?
Okay. Might take several minutes. No, it's probably okay. There you go. Okay, so on the one hand, it's altered flow dynamics, and that, like I said, we can see from either a computational model, or we can also obtain that information directly from MRs. So it's almost the last one. Where is it? There it is here. Thank you. There we go, altered fluid dynamics, like I was saying. So this is something that we can measure non-invasively. So for us, it's very important. What else can we measure non-invasively? And what we can also measure non-invasively are altered strain patterns that can be related back to this altered mechanics, right? So if you have an altered mechanics locally or of the whole aorta, it is going to show up in your strain. So in conclusion, we have that high degree of inter and interpatient variability is present in aneurysms, so that tells us that this non-invasive analysis has to be done not by patient, but by location in the aneurysm. And I'm going to walk you through what our proposal is to solve this problem. Proteoglycan in the media associated with regulation of both elastin and collagen. Energy loss appears to be an important parameter with regards to the progression and to the weakening. And then the local hemodynamics definitely affects the structural remodeling, and we can have not only an idea of the local hemodynamics, which is supposedly a causation effect, but we can also have an idea through the strain of what is going on to that particular piece at that particular point. So if the maximum diameter or the aortic volume, which are the standard of care, as well as with the growth, do not strongly correlate with an index of weakening, structural or mechanical, then what can we do? What if we could feel the strength of the blood vessel before any operation is required? So what if we, because when we talk to our surgical collaborators, they say once I go in and if I do an open surgery, I can tell that the aneurysm is different in certain regions. I can definitely feel some areas of weaknesses. So what can we do to do that in a non-invasive way? And so what we developed is a software that allows us to estimate the strains, the local strains. So here what you have is the software working. So we do image acquisition, we develop the mesh, and we have an optical flow method that is able to contour our aorta and look at the kinematics. So this is not a model. So many people, when we present this, because they see the mesh, they right away think about a finite element model. The beauty of it is that it is not a finite element model. It does not impose any assumptions. It's just the way it deforms. So for those of you who may have been in one of my classes when we do kinematics analysis, or any other classes that you've taken in mechanics, kinematics is the study of motion, regardless of the forces that cause it. Okay, so we do the kinematic analysis, and then we do the fluid dynamic analysis, and what we have come up with is this RRP, the regional rupture potential, which takes into consideration the flow dynamics and the strain and the presence of thrombus, if it's present, puts it all together and shows us and correlates with strength. So like if we go back to our case study of the double aneurysm, I told you there's a very big difference between the upper and the lower aneurysm, and it's a combination of things, different hemodynamics, different stiffnesses, different strength, and it seemed to all be actually correlated with our RRP. So our upper aneurysms had higher regional rupture potential for rupture, so higher risk for rupture, and indeed it was weaker. And our lower aneurysm was not normal by any stretch of imagination, but was a lot more strong, and it is reflected into the RRP. If we then look at our case study 2, we have a bunch of those. This is quite a unique case because this patient came into, was admitted into our study. So we had ethics permission to obtain their images, and then while the patient was in the hospital for their CT scan, it was found to have what the surgeons call an intimal rent, which what it means is that a contained rupture. So the intimal portion was ruptured, but it had not burst because it was contained by the adjacent structures, as well as potentially some of the structures inside the aneurysm. So it was in essence ruptured, so the patient was wheeled into the operating room. In the meantime, we received the images without any indication of what had happened to the patient. So we did all of our analysis, and what we found is that the location of rupture correlated with a high index of what we call RRP. So here I can show you the fluid dynamics. So the fluid dynamics, if you look in very detail, you see that it's somehow disturbed at the location of rupture, but alone it wouldn't allow you to figure out that it was the point that might have ruptured. Thrombus, there was quite a bit of thrombus, which is also an indication that the fluid dynamic had been altered for quite some time. What was also interesting is that in this area, there were some areas, it was very heterogeneous, but there were some areas of high strain, which is an indication that the wall potentially was weaker. If you put all of this together, the RRP, so individually they don't pinpoint that location, but the RRP pinpoints that location as a location of rupture risk. Other locations were also quite weak, and it's not so important for us to determine where it ruptures. Of course, it's important as a validation system. We don't really care where it ruptures as long as we know that it's at risk, enough at risk. So for that being said, let me thank all of the students and all of the people that have really actually done the work, and all of our collaborators, and one of our most successful hikes. Thank you very much.
So we have some time for questions. Yeah.
Very interesting about the surgeons saying they use their sense of touch. I'm wondering if you tried to validate your algorithm against what they feel at all, or if there's a way to do that to see if it lines up with what they...
Very interesting point. What we're really interested is whether his sense of touch corresponds with actual weakness in our machines. But yes, no, absolutely. The reason I say that is because I want to give you the idea that if actually you could, right, if you could touch it before the operation, you would potentially be able to find weaknesses. So they don't really use their touch for that, and also it's too late once they're operating.
I'm just curious what happens with the flow as an aneurysm gets worse. So does the flow change the tissue, and then does the changing tissue affect the flow?
Very good question. So The answer is we don't know. It seems to be a little bit different in the abdominal aorta with respect to the ascending. But let's look at the abdominal. So the abdominal aorta, it seems to go towards first some weakening of the wall that creates area of flow recirculation. It is quite interesting that the aneurysm is always just above, or not almost always just above the iliac bifurcation and below the renals, where there are some flow disturbances already. So if you have already some flow disturbances, any additional flow disturbance would start the cascade that starts with recirculation, platelet activation, thrombosis, and then eventually that may, so a thrombus is again dead red blood cells, as well as a lot of proteolytic factors. So you've got a lot of MMPs, so it's almost like a factory of bad things that then travel to the wall and potentially degrade the wall. At this point, when the wall gets degraded, it might go a little bit more. In fact, if you follow growth of aneurysm, it seems to happen in spurts. So it's you go at a certain level, then it degrades enough, becomes bigger. Then when it's bigger, the body probably sees that there's too much blood that is sequestered at that area. Each cardiac cycle, or no, we need some more blood, and it continues. There are some aneurysms as well. Only about 20%, I think, but there are some that don't have thrombus, and there are also some that have thrombus only in some regions. So our double aneurysm did not have any thrombus in the lower region.
One of your goals is to develop a method that can be used research. And how far are you with that?
So we have a couple.
The slide that you showed looked that you are quite far.
We are getting there. So we have a couple of patents on some of the indices as well as the method to come to our strain analysis. And we developed this software that we call Vita. Some of our students, or one of the students involved, she is now a postdoc and has applied for MITEX funding to proceed towards commercialization. We also founded a startup to take it to the next level.
Frank and then Arash.
I guess my question is along those lines. How do you go about, or how did you go about validating the RRP algorithm? Because it seems like you have to kind of weight the fluid terms and the thrombus and the strain terms.
Excellent question. So, so this rupture in the hospital, I don't think it's going to happen again, right? So, I mean, we're not waiting for that. It was a really, and it was good for the patient as well. So if your aneurysm has to rupture, better it be in the hospital. But I don't think it's going to happen. So we are recruiting patients both here as well as in Montreal, and we're trying with Sweden. They have a wonderful hospital at Karolinska for aneurysms. A little bit difficult to get all the ethics approval. So basically to follow patients and talking to our surgeons. So what we asked, for example, our colleagues in Toronto is, what do you need in order for this method to be useful for you in the clinics? And what they tell us is if we can basically predict growth and those spurts of growth, because eventually growth is linked to weakening, right? And so growth. So we're trying to do that, but that is a really a long game, right? And in fact, when we were starting to develop our ideas for the company and also talking regulatory, I can't validate, right, this method until I have 10 years, maybe less, but until I have many years of patients having, or doctors having used the method, right? So what we're going towards right now is these two things. So what we have is we have a physical, not a clinical validation. We have when we say it's weak, it is weak. So what we validated it is through testing of our aneurysm. So the high RRP correlates with a high strength. High RP correlates with low strength. And indeed, also when we look back, in Pittsburgh, I had managed to go into the OR for rupture patients. So we used that level of stress, ultimate stress that I have developed in Pittsburgh, and it correlates with our RP. So this is a physical, it's not a clinical validation. So I try to tell everybody who asks from a commercial point of view, we don't know what weak means in terms of clinical outcome. However, are, it's weak, it's going to be bad. We have a physical validation. What we decided to do is that our first product is going to be a mapping, so aortic mapping. So we can tell you that some areas are weaker, some areas are less, and you can use this information to map your surgery, to map your endovascular. In the endovascular operation, to have a weak neck, for example, is hugely puts the patient at risk. And about 30% of those endovascular stentings, so when they don't open, and now there's about 80% of surgery are endovascular, 30% they fail at 5 years. So knowing why, knowing that and we can also do the mapping after the stent is put in. So what we want is we want to propose and have people use this method as an aid. You know, it's like, you know, when you're a surgeon and you look at a CT and you look at a tumor or something that's enlarged, or for example the PSA, the prostate indices, they do not correlate with clinical outcome, but they help the surgeon make decisions.
I'm not sure if I actually understood correctly, but you said that if the flow is laminar, it's going to be better, lower risk of injury and turbulence.
Now, I stayed away from saying laminar and turbulent. The flow is not turbulent in these aneurysms, but it's most likely transition, and it's definitely not. So there are recirculation more than turbulence. I don't think we can talk about turbulence per se. The Reynolds numbers would probably be in a lower order, not turbulent. But yes, so disturbed flow, that's what we call it.
Then there was no correlation with the diameter of the.
Correct. So the diameter does not correlate with how strong your wall is. Now, the diameter, I mean, it's not good. If you have a 10 centimeter aneurysm, it's not good. I'm not saying that, but it does not correlate directly with strength. And that's why there are aneurysms that rupture at 4 centimeter, 3.4, where they are below the cutoff for surgery. And then there are some that stay stable for the remaining of the patient's life.
So I was just thinking that maybe if the diameter is changing,
Absolutely.
That would actually affect the.
It does, right? So any kind of changes in shape would then start a cascade of the flow being disturbed, and there's thrombus formation.
Can one affect the wall strength through nutrition or supplements or something like that? I know it's in your field, but I thought.
Right. You tell me, right? It's. I guess that's why, and there's part of this study that's been done in Dr. Rinker's lab, and they're looking at RNA as well. And why is it becoming weak? I mean, it's for us, it's more of an index, right? We can see that it is weak. We don't really know why, right? And also in terms of the fluid dynamics, it's more of a correlation. I don't know if it's a causation. So could you start exercising, and that would give, for example, perhaps exercising would make your flow more laminar. That has been shown. Is your flow more laminar going to protect you from further developing your aneurysm? That's possibly true. That at the same time, though, if you exert a lot and then you start having a burst of pressure, you may rupture your aneurysm. So.
John first.
One thing you didn't mention was pressure, and deforming the vessel is going to change the pressure distribution. And so how is that related to the strength of the wall? Because that's going to be the motivation that actually ruptures it.
Correct. So the aneurysm will rupture not because of a wall shear stress. So the interface between the wall and the wall shear stress in terms of magnitude is a lot lower than, say, a stress directed or circumferentially, for example, which would be due to your local pressure, for sure. So when we do fluid dynamic analysis, of course, the pressure is one of the variables, which we haven't shown, but of course we have that. And like you said, even though in very simplistic terms, the pressure would be kind of the same, right? I mean, if you measure your pressure in your arterial tree, is relatively constant, but of course, and especially with alteration in geometry, there are regions. And so, for example, where the aneurysm balloons out, the velocity goes down and the pressure goes up locally.
Have you used this tool as either an educational tool or a prescriptive tool for stents? So I could imagine it being used in terms of stent placement in order to reduce risk after the stent.
Stent placement is where we're going now.
Okay.
Absolutely. And it's not only the placement, hugely important, but it's also what happens then after. So these patients all come back for follow-up, and in fact, whether or not you get put a stent instead of an open surgery also depends on whether or not they think you're going to come back for follow-up. So if you live in some remote place, they may actually do an open surgery because at least whatever they've done should remain relatively stable for several years. So absolutely. So our next step is we've modified our ethics so that we can look at stents. So we already look at stent pre, so for the mapping, but equally important is what happened after, because unfortunately, so the stent is not sutured in any ways, it's just staying because of friction and because it is so bigger than it should be, and so it provides pressure, right? And it's heavily stented metal, and so if we could see perhaps, and also blood could escape both at the neck, right, at the interface between the staph, blood could escape and still filter into the cavity, and that could pressurize the cavity, as well as blood could come in from smaller vessels that are taking the blood from the aneurysms, but because of a reverse in pressure, if you put a stent in, you create a very low pressure behind the stent, so the blood could come in. And through our method, we could see what's going on. Is there blood? Is there distensibility? And sometimes this blood is so little that you don't see it in a CT for sure, and sometimes not even in MR.
Elena, you talked about the fragmentation of the elastin, and then you also did talk about collagen, and so you alluded to possible changes in the quality of the collagen. Have you got any data or speculation on what you think is happening to the collagen, the quality of the collagen?
Next week, hopefully. So all of the next samples we collected, and we're going to do hydroxyproline. So we never really looked at the collagen. So if you look at studies on aneurysm, many people have concentrated on elastin, which is a huge piece. But what we're finding is this collagen in the media, and therefore we want to know what it is, and especially since it doesn't correlate with strength. So we're going to do total collagen, crosslinks, as well as type of collagen, type 1, type 3.
And are you going to characterize maybe the geometry of the collagen? Like, is it highly coiled or is it very stretched out?
Yeah, so that we already tried to do, and we have microscopy images, and we were talking in our lab, and there's now a wonderful new microscope at Libin that might allow with some better things, as well as we're looking into a analysis software or developing something. So we have so many wonderful pictures, and unfortunately we have so many specialized methods to analyze everything, except for the microscopy we're like, yeah, it's undulated. I mean, I think it's our least advanced piece, so that's what we're advancing.
Do you know if there's any animal model to look at it? And if so, how do we use aneurysm?
Very important question. So in the animal kingdom, not many animals develop aneurysms. However, horses do, and I believe giraffes do. So that's maybe not your most easy animal model. So if you look at the history of trying to, yeah, it's huge. Of course, you wanna try. Now, try to look at it in a very concrete way. And we've done some animal studies with Dr. Mehta at the hospital on rabbits. So if you infuse elastase, for example, you form an aneurysm. Is that an aneurysm? Is that you destroy the elastin? Of course, it's going to go out. In fact, when we normally these kind of study go to the 4-week, 5-week. When we went to 6 weeks, it seemed as if the rabbit, he didn't have an aneurysm. We created one. It seemed as if he was trying to repair it. So was that aneurysm a sort of more of a scar tissue? So we're not so convinced. However, in the last few years, there's been huge studies on mice. Now, certain types of mice do develop aneurysms. Some are genetic, the ascending aorta are genetic. Some are the ApoE fed a certain diet, do develop aneurysms, and then if you do elastase, it seems to reproduce. However, think about that. If it is an elastin problem, right? Elastin is a protein that's very similar across the animal kingdom, okay? So now you take your elastin in a human and these problems start arising, when you're 50, 60, 70, because possibly the elastin has aged. And there are some studies now that look into elastin fatigue because elastin doesn't get replaced in the body, right? Now you look at the mouse, right? And so in the mouse's life, you'll never have older elastin, right? You'll never have fatigued elastin. So any kind of model, you have to be really, really careful what you're doing. Are you just breaking down the elastin, but it's not. Now, what my colleague, for example, at Yale, Dr. Humphrey does, he says, yes, but what we use is a mouse that has altered elastin. So we're basically saying, if you have a mouse that has altered elastin, that kind of reproduces the idea of the altered elastin with age, but it's altered, sorry, complex question.
We have a question from the viewer. The question is, you show a 50% loss of elastin in the aneurysm region. Do you think that this is a local issue only, or perhaps due to a local injury, or is it a general aging issue? And does the healthy region of artery have normal elastin levels in these patients?
That is. So first of all, does the normal portion of the aortas for these patients have normal elastin? I don't know, because they only allow us to take the bad pieces because they're happy with their aortas in the other regions. However, we have a lot of studies on cadaveric aortas. Now, you have to understand that when we obtain the aorta, we have to be very careful. Did they die because of a cardiovascular issue? Are they really old? So it's very, very difficult. But it seems as if the elastin degrades with age, no question asked. In an aneurysm, is more accelerated as well as local. Okay, so there's a local piece. So for example, we do a lot of pig aortas, which are not exactly the same, or quite similar. And if you look at the percent in a segment, anterior, posterior, they're very similar. In an aneurysm, they're not. In fact, when we do the what we call the Chicago study, even though we do it here as well now, we have differences in the same aorta. An area that had high shear, an area that had normal shear, very, very different in terms of elastin content. And then to answer the question about is it an injury, if you can call bad blood flow an injury, then it would be an injury.
We have time for maybe one last one. Brett.
One thing that I wanted to get clarification on when you showed the upper aneurysm data versus the lower aneurysm data. What were those relative to? Were they just relative to each other? So you're saying tissue from upper aneurysm higher than, like, more inflammation than the lower aneurysm, or was it relative to some other?
It was relative to the population of aneurysms that we tested, which is only 8, 9, so not that many, but many pieces. So on average, that aneurysm was on the high side of inflammation for our cohort. And then it was higher than its own control, if you want, the lower aneurysm.
And then the last one, if I understood what you said before, was that you can have very similar shear stresses from the fluid flow model or tensile stresses from the kinematic model, but very different constitutive components or very different amounts of collagen and elastin.
Right. Well. No, what I said is that I don't know what I said, but what I meant is that the aneurysm itself, even in one single patient, can have very different properties. That I'm talking about invasive. When I talk about properties, I'm talking about invasive. So the strength could be 20 times in the same aneurysm. This piece is 20 times stronger than this piece. Okay, and then it could have a lot more elastin, a lot less. If you look at the non-invasive piece, so that is the fluid and the strain, huge differences there as well. So I would say that they are actually correlated. In fact, now we try to have an additional piece that I haven't shown, which is to take pieces that are very homogeneous in terms of strain and shear, so that maybe the signal is more clear.
So it makes me think that there's probably a level of stochasticity to these injuries or failures or whatever you want to call them. Do you have the resolution with the clinical CT and the MR to actually get the measurement that you might actually need to be able to quantify risk?
So I think we have the resolution to quantify risk because it is, the rupture is at a millimeter scale. It's not at a nanometer scale. So yes, I believe we do have the resolution to do that. What we don't have the resolution to do is to do a sort of so in many labs, and we tried as well, they look at perhaps the collagen orientation, the elastin, and then they develop constitutive models that take into account the orientation of the fiber. That's a lot more variable and it's more stochastic, I think, and in fact I'm trying to stay away from that. The new microscope at Libin is now able to do millimeter views instead of 50 micron, the usual, so that's promising. However, I think that in order to do a constitutive model, so if you notice, we do constitutive model in the lab a lot, but if you notice, we're trying to show you properties, right? So energy loss, not the model. Why? Because I think there's a stochastic piece, and so I think that you should say the collagen changes in this way, in the stochastic way, and on average, I've just visualized here and here, and perhaps through the way that they deform, you can then utilize it to improve your model, but there has to be a stochastic piece, and I'm really excited that you mentioned that, because you and me are the only one who think this so far.
Excellent. So on that note,
Awesome.
join me in thanking our speaker today.
Thank you.